Hello to you all and welcome back to my channel. My name is Tommy. I am a human nutrition student and researcher at the university. What I do in these type of videos is to synthesize my classes so then I can explain and teach you the best and most valuable information you need to know. Today we're going to continue the pharmacology series of videos and we're going to take a look at the digestive system drugs. So the drugs we use in the digestive system. So let's begin. Interactions in pathologies of the digestive system. To treat the peptide ulcer and the gastro-esophageal reflux. Let's take a look. So there are three ways of controlling the acid secretion. We have three receptors. The gastrin receptors that are triggered by gastrin, histamine H2 receptors that are triggered by histamine, muscarinic receptors M1 and M3 that are triggered by acetylcholine. The target here is to treat the Helicobacter pylori infection and treat the heartburn, indeed, the reflux. So we have three things we can do. The reduction of acid secretion to enhance the gastric mucosa or the use of antacids. Starting with the reduction of acid secretion, we can have the proton pump inhibitors so that they inhibit the proton secretion, there's no acidity, or the H2 receptor agonists, which are indeed H2 antihistamines. And remember, histamine is correlated with acid secretion. Proton pump inhibitors are, for example, the omeprazole. A prolonged use of this, though, will create hip fractures because lower acid in the stomach is correlated with a lower calcium absorption and a lower intrinsic factor for the vitamin B12 absorption in the intestine. Lansoprazole and pantoprazole are not metabolized by the cytochrome P450, and these are the only ones of this family. And they are good in polymedicates because of this thing exactly. Food will lower absorption of ionsoprazole and esomeprazole, and it is best to take them 30 minutes before meals. Indeed, this family of drugs are recommended to take in the morning before the breakfast. They can create digestive discomfort, nausea, diarrhea, and abdominal pain. On the other hand, we have the cimetidine, ranitidine, and famotidine, which are H2 receptor antagonists. They may mask the gastric cancer symptoms, and they are less effective than the proton pump inhibitors. These are meant to be taken in the evening and cimetidine on an empty stomach. Cimetidine is not marketed in Spain though. They can create dizziness, tiredness, and skin rash. Enhancers of the gastric mucosa. We have the misoprostol, which is a synthetic prostaglandin E analog, and it promotes healing of the mucosal barrier. This drug is not recommended for hypotensive people, nor for pregnant or lacting women because of abortion. Indeed, they can create diarrhea and abdominal pain and sometimes spontaneous abortion. So be careful with that. On the other hand, we have the chelates. Here we have the bismuth subcitrate. It inhibits the pepsin action by binding to it and creating an insoluble residue. Then it also increases the production of protective prostaglandins and it will increase the bicarbonate secretion, so decreasing the acidity. It is not used in renal failure and interacts with calcium because it creates insoluble precipitates. It can create digestive discomfort, nausea, diarrhea, and abdominal pain, the same as the proton pump inhibitors. And then we have the antacids. These are aluminum hydroxide and magnesium carbonate. These are alkaline salts and they will increase the pH, so lower the acidity of the stomach by binding to the pepsin and inactivating it. This is not used in hypopotasemia and it can cause constipation and diarrhea. Together with citric acid, there is aluminum toxicity because aluminum absorption is boosted. So we have to space them at least 3 hours apart. And in more detail, constipation comes from the aluminum salts and the diarrhea from the magnesium salts. And now nausea and vomiting. Vomiting is a natural reflex to ingestion of toxic substances, medicines, and illnesses. And it can cause metabolic alkalosis because you get rid of the acidity of the stomach. There is a neural control of nausea and vomiting. We have the vomiting center, which is in the medulla oblongata, and it is stimulated by the vestibular stimuli, visceral, and the chemoreceptor trigger zone stimuli. The chemoreceptor trigger zone is the other area of control, and this is a cluster of neurons near the emetic center with dopamine and serotonin receptors. So these two are really linked indeed. They are really close to each other. So here we have different types of drugs. Starting with the H1 antihistamines. Here we have the dimenhydrinate. It blocks the H1 and muscarinic receptors, and this will create a sedation. Be careful in prostatic hypertrophy, urinary retention, and glaucoma. Indeed, it creates sedation and somnolence, inhibiting indeed the nausea and vomit symptoms. Then we have the dopamine antagonists, domperidone and metoclopramide. These antagonize the dopaminergic receptors in the chemoreceptor trigger zone. We have to limit the doses of metoclopramide, and they can cause drowsiness, sedation, hypotension, and extrapyramidal symptoms because they are correlated with dopamine. The domperidone only in adults and does not cross the blood-brain barrier. And there is a slight delay in absorption of the metoclopramide when taken with food. And then we have the serotonin receptor agonists. Here there is the ondansetron, which antagonizes the 5-HT3 receptors in the chemoreceptor trigger zone. It causes constipation, diarrhea, abdominal pain, and dry mouth. It is metabolized by the cytochrome P450, and because of that we have to be careful with the grapefruit juice. Another remedy for nausea and vomits is the use of synthetic cannabinoids, such as nabilone. It has antiemetic properties, so stopping the vomiting signals, when it starts directly in the chemoreceptor trigger zone. So very effective when it starts here, and not in the vomiting center. Intestinal motility. Peristalsis with aim of transporting, mixing, and propelling the contents in the caudal direction. This is what is used for the peristalsis, and it is very important for us. We have a narrow control of the peristalsis using myenteric plexus and submucosal plexus. The main target of the drug treatment is the narrow control. But we also have an hormonal control, endocrine, using the gastrin, as well as paracrine substances such as histamine, secretin, the cholecystokinin, and the vasoactive intestinal peptide. Drugs, motility stimulants, for example the domperidone and the metoclopramide, again, they can work as motility stimulants as well. These are antiemetics that may increase gastric and intestinal motility without the laxative effect. They can cause drowsiness, sedation, hypotension, and extrapyramidal symptoms because they are correlated with dopamine. Then we also have the antispasmodics. These are the muscarinic receptor antagonists, the atropine and the cycloverine, and they will inhibit the sympathetic activity, promoting the smooth muscle relaxation. These are not used in the gastro-esophageal reflux, and they produce cholinergic adverse effects such as dry mouth, blurred vision, dry skin, tachycardia, and urinary retention. On the other hand, we have the drugs acting directly on the smooth muscle. So here muscarinic receptors, and here directly. Here we have the mibivirine, which reduces the smooth muscle spasms. It is not used in paralytic ileus and may produce nausea, headache, and heartburn, so reflux. And now it's time to talk about constipation and diarrhea. These are correlated with intestinal motility indeed. Constipation, we use the laxatives. They accelerate the intestinal transit time and they promote the defecation. These are used to relieve the constipation and cleanse the bowel as well. Types, we have the dog fulmars, the methylcellulose, and the spagula, the plantago ovata. They will increase the volume of non-absorbable solid residue, distend the colon, and increase the peristalsis. These are not used in dysphagia, intestinal obstruction, or fecal impaction. They may cause flatulence, abdominal distension, and digestive obstruction. Then we have the osmotic type, lactulose and macrogoles. These are poorly absorbed, and they are meant to do that. They will increase the osmotic load and they will trap the fluid in the intestinal lumen, and this has a diarrhea effect. It is not used in intestinal obstruction though. It can cause flatulence, colic pain, abdominal discomfort, and electrolyte disturbances because of that osmotic load. Stimulants. We have the senna, the casquerosagrada, sodium picosulfate, and bisacodyl. They will increase the secretion of water and electrolytes from the mucosa, not used in intestinal obstruction, and they may give short-term cramps, impaired bowel function, and colon atony. Because it starts to secrete a lot of electrolytes and water, therefore atony may happen. And then we have the emollients, laxants. Here there is the liquid paraffin. lubrication of the stool to promote intestinal transit. It coats the stool with an hydrophobic layer, trapping the water inside so it cannot get out. And it acts after 6 to 8 hours of ingesting the laxatives. Not used for children under 3 years of age. And there is an interaction with absorption of fat-soluble vitamins, because indeed they are not going to be absorbed because this hydrophobic layer blocks their absorption. So we have to space at least 2 hours. And last but not least, we have the diarrhea. Frequent liquid stools, when there is a lot of motility, a lot of secretion, and a lower absorption of liquid. Here the main one is an opiate type antimotility drug, the loperamide. It acts on opiate receptors in the myenteric plexus. It increases the tonus and the rhythmic contractions, decreasing the propulsive activity. It is not used in acute ulcerative colitis and not recommended in children. It can cause nausea, vomiting, abdominal cramps, constipation, and drowsiness. On the other hand, we also have other antidiarrheals using chalk and charcoal. These act by adsorbing toxins. These act like magnets in the intestine, binding to the toxins. They are not used in acute diarrhea though, and they may reduce the absorption of other drugs because of this principle of adsorbing. And they are taken without food because they can also interact with the nutrients absorption. Okay, that's it for this video. I hope you understood everything I said. If you didn't, there is a comment section down below. Remember to download these diagrams by clicking in the first link in the description. Don't forget to like, subscribe to the channel, and share this video if you found it helpful. Thank you so much for watching, and I will see you in the next one. Ciao!